My friends, I wanted to talk about headaches because, like dementia and like many other challenges that we face, the primary recommendation for headaches is to take medication. And oftentimes, all they do is take care of the headache in the moment, and then spin cycle occurs, and we go back forth, back and forth, back and forth. So I want to give you some updates, some insights, and interventions that you can be thoughtful about if you are one that struggles with headaches. Okay. So first of all, my goal today, excuse me, is to talk about the different types of headaches and talk about their characteristics. And I want to teach you what referred pain is, right? Referred pain is so important to understand headaches. And then I'm going to finish my presentation by talking about the importance of your neck when it comes to headache. So, first of all, migraine headaches, everyone hears about them. We talk about them a lot. We talk about a migraine that has an aura or no aura. No aura is probably the most common type of migraine headache, although headaches with aura, migraines usually about 25 to 30% have an aura. Well, what in the heck is an aura? Auras are believed to be caused by an electrical or a chemical wave that kind of spreads across the brain that impacts your sensory nervous system, your motor nervous system, and sometimes your ability to speak. And so I Googled some pictures. What are some examples of auras? And these pictures are kind of, I like them. I think they're good examples. I personally have never experienced a visual aura, so I can't talk about it on a personal basis. Thank goodness, right? No one would wish that on anyone. But an aura is often very variable from person to person, and the literature describes them as a flashing light or a zigzagging line. Sometimes you see stars or sparks or blind spots. Tunnel vision can be an aura. There are other types of aura that are not visual. There can be auras that are numbness and tingling or sensations of electric shocks or even ringing in the ears. There can be an aura of your speech, so slurred speech or people can't find their words. Even motor coordination and discoordination can be all parts of an aura. And these typically occur before a migraine starts, and they usually will last maybe 5 minutes. They can last up to a full hour before the migraine begins. There's phases of a migraine headache. The first phase is kind of that pre-headache. The medical term that we use is a prodrome phase. It's kind of these subtle changes, and you get these warning signs. Hey, this migraine's coming, and everyone who suffers from migraine knows that's happening, right? They start scrambling for interventions. These prodrome phases can include things like fatigue, or you yawn over and over, you get more irritable and a stiff neck. Constipation, interesting, we were just talking about constipation, and light and sound sensitivity can be a part of that. And then the aura starts if you're one that gets an aura, or the migraine starts after that. So a migraine is this throbbing, pulsatile. Often a migraine is one side of the head. And I made that in blue because I'm going to be talking to you about the different sides of the head and how they apply to headaches. Sometimes it's worth with physical activity. Sometimes it's included with nausea and vomiting and light and sound sensitivity. I mean, a migraine really is a headache from hell. This is awful. And then there's this resolution phase, or the medical term is a postdrome phase, where people are exhausted, man. They just want to go to bed. And a lot of people will say they slept for an entire day after. They just had to turn the lights out because they're brain foggy and they're dizzy, and you turn the lights on and they're miserable along the way. Okay. Lots of discussion from experts about migraines, and I included this study here. This is Dr. Andrew Charles from UCLA. He printed this summary in the Lancet, and he goes through step by step and talks about the best that we understand migraine headaches in these graphs. Now, I'm not going to go through these in detail. That's not my goal. I'm not teaching doctors how to do, how to manage a migraine in each one of the steps, but I do want to point out a couple of things. Dr. Charles talks about the neck and how the neck is contributory to that. So I'm kind of leading you up to how I'm going to finish my presentation. And as I read through this article, it's fascinating how the physiology of a migraine is actually very similar to the physiology of a concussion. in that you have a trigger, and in a concussion, you get hit. The second thing is you get this really chaotic nerve firing. So in a headache, you might get visual changes, all those auras we talked about. In a concussion, you have a seizure or you have a loss of consciousness. So that chaotic nerve firing causes glutamate, which is a receptor in the brain, to be released. And then your brain just releases all these pain enhancers. They're like inflammatory markers or cytokines, right? And one's called a CGRP. The other one is a PACAP. I'm not going to go into even what those are chemically. But that then enhances and activates certain parts of your brain. One is the thalamus and one's the trigeminal nerve. And there's a lot of new medicines that have recently been released to block CGRP, right? Or to block, there's monoclonal antibodies that will actually block the receptor sites of CGRP. And I've listed them at the top of your screen. These medicines really have been game changers. They're amazing. But the tragic thing is I've prescribed them a number of times and I seldom can get the freaking insurance companies to pay for them because they're very expensive. So here, that's the challenge. They're out there and they're new, but they're really expensive. And you kind of have to have an act of Congress to get insurance to cover them. It's kind of discouraging that way. So how do we then treat migraines? Besides those medicines that I just talked about that are hard to get, we can use certain medicines called triptans, different pain medicines, opioids, over-the-counter medicines like Tylenol and ibuprofen. Caffeine is remarkably beneficial in individuals who have migraine headaches. And then from a preventive standpoint, we can even give other classes of medicines like epilepsy medicines, blood pressure medicines, Botox. Obviously, we want to decrease the stimulus from the environment. Sometimes loud noises, bright lights can contribute to these. So this is part of the treatment where we're trying to abort that headache and get rid of it right now. There's many preventive therapies, but in my opinion, sometimes these are brushed aside. When I talk to migraine sufferers, I'll say, do you know your triggers? And they'll just really quickly say, yeah, I get triggered by this, but we can't fix it. And so we just need medicine. And I'm often thinking, wow, if we really dig deeper, I think there are some things we can do. Hormone optimization, maybe that's one reason that this is not addressed a lot, because the medical community at large is fearful of hormone risk. I'm not so much. Stress reduction, poor sleep, these are all contributors. And really any systemic inflammation, like inflammation in your gut. We just talked about constipation, inflammation in your diet, exercise, bad sleep. If we really moderate these, I think we can dramatically reduce migraines. We have to calm the nervous system generally. And this is where oftentimes I get the eye roll from people, like vagal nerve stimulation, gut health. My gosh, leading up to our discussion, was visiting with one of our participants about gut health. I think the world at large minimizes that. They don't understand the neurological tide between the gut and the brain. Stress reduction, mindfulness, getting out in nature, right? It really can calm the nervous system. Meditation would be another part of that. And then you always have to fix your neck. You have to pay attention to your neck. More to come on that topic. Let's move into a tension headache. And I want to show you some pictures here. A tension headache often is described as a band that wraps all the way around the head. It's kind of this dull, achy headache. Oftentimes this is on both sides of the head versus a migraine might be more one-sided. The neck is included. I'm going to talk about that, right? Often it's described as a steady pressing or this tightening, not a throbbing, but more of this tightening, this band-like. This is why they're called tension headaches. It feels like you got a band wrapped around your head. There can be tension in the scalp, neck, and shoulders. They're often very episodic, but there's people that have maybe some chronic musculoskeletal problems so these become more frequent and more repetitive. And then they're often triggered by stress and poor posture, muscle tension. Aha, interesting. I'm going to come back to that. Let's talk about cluster headaches for a minute. Let me show you a quick picture. I love this picture. A cluster headache is often one-sided, but unlike a migraine, it's in a very focused area. And some people describe cluster headaches as some of the most severe and intense piercing pain, like you're getting, someone's putting a drill or an ice pick right in this one area. And oh man, it just rocked my world. Some people have described it as the most painful type of headache ever, and it's commonly listed right behind your eye or in the temple area or the forehead. Now, I put right behind your eye in red for a purpose, right? I'm baiting you. I'm baiting you to think of neck, banding, location behind the eye. Instead of just thinking of these headaches, I'm going to talk about referred pain here in just a second. Associated symptoms can often be watery eyes, runny nose, a drooping eyelid. These are scary because sometimes people think, oh my gosh, I have the worst headache of my life and I swear I'm having a stroke because my eyelid has changed. So a good practitioner has to go through musculoskeletal testing to make sure we're ruling out a stroke, right? A stroke would affect the entire body or parts of the body, not just the eye itself, the eyelid. Some people start sweating, they get restless, they're super agitated because they're so miserable. Now, these are generally episodic, but some people, if they have an underlying condition, they can certainly turn into cluster periods. That's why we often call them a cluster headache. One trigger that was pretty interesting is these are associated with alcohol. I did not know that before I put together this presentation, that I kind of just assumed that a hangover is the same thing as a cluster headache associated with alcohol. And the literature is pretty clear that that's not the case. But certainly alcohol can be a trigger of a cluster headache, even though it's not the same. Some of my clients will say, I got a sinus headache. And really what they're saying is, I have a sinus infection and it's giving me a headache. The medical literature is different than what patients say. The medical literature says they probably have a tension headache with some sinus congestion. Isn't that interesting how the lay view of these headaches and the medical view of these headaches are actually quite different? Obviously, the sinus headache, if you will, are pain and pressure over the sinus area. And so I've given you a picture there of your maxillary sinuses, your ethmoid sinus right between your eyes and kind of at the bridge of your nose, the frontal lobe, right? All of these things often associated with a nasal congestion, runny nose, postnasal drip, and so forth. Okay, so I have a good friend who's a PA. I have worked with him since 2006. This guy's awesome. He's almost been with me for 20 years. At one point in time, we calculated that he has done over 250,000 office consults in urgent care. He is the most popular guy in town. And he said, I told him, he said, what are you presenting on this week? And I said, I'm presenting on headaches. And he says, oh my gosh, the longer I practice medicine, the more I think the neck is the trigger of most headaches. And I thought it was so fascinating that he said that because I already built my slide deck. And then that was the comment that came out of his mouth. So I'm going to talk about the neck and its contribution to headaches. Have you ever heard of a cervicogenic headache? Now, I'm guessing that most of you listening to this have not heard that term cervicogenic headache. Now, it's going to make sense. I'm sure that you've appreciated this. This is a headache that occurs secondary to an issue in the neck. Sorry, I got a typo right there. Let me actually fix that while I'm in. So it's a secondary headache because there's a problem in the neck. And that problem exists because there's a problem with the vertebrae or the joints. These are called facet joints. Let me show you a picture of the facet joints right there. So the transverse processes that come out of the cervical vertebrae, they have a joint on them called a facet joint, and those articulate or they rub on each other, right? And it can also be a muscle. So look at these muscles on the left-hand side of your screen. The muscles that are shown there are only the suboccipital muscle groups. So it's so fascinating. Look how many there are and look at how they attach. Some of them attach to the spinous process and some of them actually attach to the transverse process. So it can be muscle and ligament and disc and nerve and so forth. And the characteristic and the behavior of these types of headaches depend on what in the world is happening in your neck. But they're a type of referred pain. So now you're asking me, well, what is referred pain? Let me give you an example of this. The definition of referred pain is when referred pain occurs when there's pain originating in one part of the body, but it's felt in another part of the body. And it happens because the nerves from each of these areas kind of converge in the same pathway of the spinal cord. And so it causes your brain to misinterpret the source. So the best example that I can give, and everyone gets this, is everyone knows that a cause of or the symptom of a heart attack, it's really easy when someone says, "Oh, I got this crushing chest pain like an elephant is sitting on my chest, and it's right under my sternum." So it's this substernal pain. Everyone knows that's probably a heart attack. You've got to go to the hospital, you got to get checked. And most people also know if you get left shoulder pain or left neck pain or this pain that pulsates and radiates into your jaw, it could be your heart as well. Many women experience a heart attack very different than men. Women will get acid reflux or indigestion. They feel nauseated. Men can have nausea as well, right? This is a type of referred pain because the nerves that create the sensation in and around the heart are they have the same nerve track as our left shoulder or our jaw or our GI tract and so forth. So there is a direct relationship between your neck and the referred pain that's going to your head and causing a headache. And this is one of the take-home messages I really wanted to seed in your minds today. So I'm going to give you an example of this. If you had a really stiff neck and I came over and started rubbing your neck, I would find these trigger points underneath your skull and at the very top of your neck on either the right or the left-hand side. This is called the suboccipital area. And there's the muscle grouping that I just showed you, right? But now there's this referred pain. And did you see how many times when I was talking about the different headaches, it described it feels like there's a band around my neck, or it feels like I have this intense pain right behind my eye and I get light sensitivity. That is a referred pain, oftentimes that is emanating from the neck. And so people will go to great lengths to calm these muscles. Look at this is an example of someone doing some dry needling. Others might say this is acupuncture. Now, the truth is they're very similar. Acupuncture as a form of Chinese medicine is placing a needle in a very specific acupuncture point, but it may not be where the muscle tension or the pain is. It might be in an area where it tracks a flow of energy. So there's some combinations here between acupuncture and dry needling. Dry needling would be actually putting a needle, like an acupuncture needle, directly into the muscle belly so that we can calm that muscle down. So they both have their place, right? I am not trained in acupuncture, but I can tell you I have put needles in just about every part of the body, except for the eyeball. I don't needle the eyeball ever. But I've done tons of needling in the neck, trigger point injections, and just dry needling like you see in this picture. And why do we do that? And I could get deep into the physiology, but every single muscle group, deep inside that muscle group has something called a muscle spindle. And the muscle spindle is kind of where the sensory area of this muscle resides. And so it's in the belly of a muscle and it has proprioceptors and it manages the contraction of that muscle so we know where we're at in space, right? It relays that sensory information back to the neck and back to the spinal cord. Aha, now you know I'm talking about referred pain. And it impacts muscle tone. And it prevents that muscle from overstretching. So our muscles get really, really tight. So if you look at all of these nerves, every single one of these where the black arrows are flashing is a nerve group that's transmitting information either to the spinal cord or to the brain. So now you're saying, oh my gosh, that makes so much sense why we can get referred pain from a tight muscle or a joint in our neck that's locked up, and how it refers directly to the brain. So a lot of people will do a chiropractic cervical adjustment. They'll go in and get a little massage, and then we'll adjust those facet joints in the neck. I think it can be very valuable. And why? Because if you're misaligned, one muscle is going to be overly stretched and another one's going to be really contracted. So if you work on this with just some manual therapy, some massage, some tension release, maybe some dry needling, and then you adjust the neck, my gosh, you might prevent the frequency of these headaches. And I've actually done a fair amount of this in my clinic. I started doing more when I got trained on the relationship between neck pain and concussions. It's fascinating. So I want to show you several slides. I did not make these slides. I've tried to refer to the different organizations that made them. But my point is to show you, here's the trigger point. You can put pressure on that part of the muscle. Like this one talks specifically about the traps, that trapezius muscle. And there's the upper trapezius muscle that's more in the neck or the shoulders. And then there's the lower trapezius muscle that's kind of between your shoulder blades and goes down your T-spine. Look at all those trigger points. And each one of those trigger points has an example of referred pain. The red dots go into those shaded areas where if I put pressure on a trigger point and I put enough pressure, it's not uncommon that the patients will say, dude, you just caused that pain behind my eye. It's identical. Oh, you just gave me a massive headache because of that referred pain. Look at this beautiful picture here of all the referred pain patterns that can happen when the trapezius muscle gets really tight. And you'll see over here on the left or the right-hand side of your screen, most of this referred pain is showing where it goes up into the head, right? So I have a belief, much like my partner Nick, that so much of headaches are related to the cervical spine and that referred pain dynamic. So here's an example of doing some dry needling or acupuncture in the trapezius and suboccipital muscle. So the top picture up here, this is suboccipital, and the trap, this might actually be splenius capitis or splenius cervicis. And then these muscle groups down here are the trap. This is the lower trap. And you can see on the right-hand side, they're really gripping. They're putting a lot of pressure and gripping that muscle. And then they'll just put that needle right in there, do some dry needling. And really remember, dry needling is to impact the muscle spindles so that that communication going back to the nerve tracts and the spinal cord and the brain starts settling down and you change those muscle spindles, okay? Here's the next muscle group called the splenius capitis. Now I referenced that in these, right over here, you see this a little bit lower on the neck. This would be more suboccipital. This is probably more splenius capitis. And I've showed you, here's the splenius capitis in a drawing. There's the trigger point, baby. You can touch that area. It's right underneath the skull. And when you touch that area, look at where the referred pain is. It's not uncommon that people will say, oh, right on the top of my head, that kills. I had a patient this week where applying pressure in that area, I did some dry needling, acupuncture needle right in the splenius capitis, and then I stuck another needle right in the scalp, right in that referred pain area, because I'm trying to affect those muscle spindles and change the communication up into the head. There's a splenius cervicis muscle. So this is a little bit deeper than the capitis muscle. And you can see it attaches further down on the T-spine right here where my mouse is. Well, there's the trigger points. You see the trigger points and you see the different referral pattern. This referral pattern for the upper splenius goes right behind that eye. Now think of that cluster headache. If you're out of balance in your neck and that muscle's tightening up, well, you're just going to get a wicked headache right behind your eyeball, right? Brutal. So here's some really beautiful examples of that. Referred pain right behind the eyeball. And look at that trigger point on the right-hand side upper really communicates with the top of your head, but this trigger point that's a little bit lower communicates more with right behind the eye and the temple region, similar to what a tension headache would do. Let's go to the next one. Here's the splenius capitis. It's just another drawing with the trigger points right here. And then here's the referral pain pattern. And that shows it being much more broad. It's not just the top of the head and right behind the eye, but this actually goes back down into the back side of the head and the occipital area as well. What's my point? My point, my friends, is when you feel that pain going on, just wicked sense in your head, If you focus on making some adjustments to your neck, I think you have more than a fighting chance of minimizing the frequency of these terrible headaches. Here's an example of some dry needling that I saw on social media, and the doctor was trying to identify, well, here's your different parts of your anatomy and your cervical spine, and here's the different muscle groups. Kind of fun. This is an odd muscle group I want to talk about. It's called the pterygoid muscles. Now, the pterygoid muscles are not the masseter. It's not the jaw muscle that you're thinking of that's right there at the top of your temporomandibular joint. And when you bite down hard and you can feel that ball right in the lower cheeks and posterior area and just above your jawbone. These pterygoid muscles are deep, but they have a referred pain right into TMJ and right into your cheeks, right? So remember that slide I said sinus headaches? A lot of people think my sinuses are causing the headache, and then practitioners oftentimes think, well, you probably have a headache and some sinus congestion. Tomato, tomato, who knows? But it is interesting to see maybe we're missing something beyond just the sinus congestion, right? So here's the pattern of referred pain. Well, let me show you what it looks like on the inside of your mouth. This would be if you chopped your jaw off and you looked up inside of the skull through the mouth, you would see these pterygoid muscles. Now, I've made my own slide. I went and said, well, what if you had, let me see the throat. The pterygoid muscle trigger points are right there where you see those flashing black lines. How in the world would you access them? Because you cannot access those trigger points from your cheek or your jawbone. So guess what? You guessed it, baby. You got to put some gloves on and reach inside the mouth and apply trigger point to those muscles. Now, about 2 years ago, I went to a TMJ continuing education class, and we spent 8 hours palpating the pterygoid muscle inside the mouth. I put my fingers in 100 people's mouths so that I could feel that pterygoid muscle. It was so fascinating. The reality is sometimes it's hard to access because people's jaws are so locked up, right? So they almost have to close their mouth, and you have to go in between their cheek and their jawline and apply some pressure right here where my cursor is. And when you apply some pressure there, oftentimes they start relaxing and they can open their mouth again. It's such a fascinating thing. I have no idea who Touch of Life Physical Therapy is, but I just like that they had some photos and they talk about how important trigger point release is of those pterygoid muscles for people who have TMJ and also have kind of this maxillary facial sinus pain associated with headaches or jaw pain. So fascinating how those trigger points also relate. The last muscle group I want to talk about is the sternocleidomastoid. This is that great big muscle on your neck. If all of you turn your head to the side and then you tuck your chin down, this muscle just sticks out. It's that great big cord that comes from the back of your neck and jaw and comes right down here and attaches to your clavicle or your collarbone. Now you'll see on this slide, there's two muscles. One attaches almost to the sternum. That's called the sternal attachment. And the other one attaches laterally on the collarbone. And so that's called the clavicular attachment. And so each of them have a trigger point associated with them. And it's so helpful to go in and grab that muscle and massage it. My sweet daughter was playing in a basketball game, and I saw her start grabbing her neck, and she'd kind of duck her head, and then she'd dribble the ball, and as soon as she'd pass, she'd grab her neck again. I thought, what is Alexi doing? So they called a timeout, and she grabs her neck and walks down, and I could see she had tears streaming down her face. I thought, oh my gosh, something's wrong. And so I said, Lex, what's going on? She's like, I don't know, my neck, it just feels like it's a muscle spasm of this muscle. And that sternocleidomastoid muscle was hard as a rock. So I took her into the locker room, and I just did some manual therapy, just like you'll see on the upper hand side of your screen right here where this hand is. He's going to do some acupuncture and put a needle in that. Well, I didn't have any needles with me, or I would have done the same thing. Instead, I just grabbed it and I held some tension there, and I had her move her neck in various ways. It took all but 3 or 4 minutes that thing totally settled down and she went right back in, finished the game, and had no problem. So the crazy thing is she did something to strain that muscle at the beginning of the game, and we just had to work on it to get it to calm down. But man, look at the referral pattern on this, right? You see that the purple dots are the trigger points on this side of your screen. The referral pattern can be to the back of your head, across the temple, into the cheek area and the lower jaw. It can go all the way up above the eye to the top of the forehead. The underside of that muscle, the part that's attached to the clavicle and the green dots, has a different referral pattern. It has a referral pattern into the ear and directly above the eyeball. Okay, so isn't it fascinating how much we talked about a headache having an impact deep in your eye, worst pain ever, a band wrapped around your neck, and we've attributed it to all of these other things. Oh, bad menstrual periods. Oh, I did too much work yesterday. I slept wrong. And very few times are we focused on the neck. I think it's so important. And so that's the part that I really wanted to share. So as I offer a summary today, and then we'll take just a couple of questions, please consider the headache type. Please consider the triggers of that headache. What are you doing in your lifestyle that might be amplifying this? What's your diet like? What's your exercise like? What's inflammation? What inflammation's going on in your body? When is the last time you pooped? Are you constipated? What's your hormone health like, right? Did you drink alcohol last night? How can we manage both the triggers and the lifestyle? Please don't forget your neck. I hope that I've impressed upon you. This lecture was biased. This lecture was really focused on, hey, here's all the different types of headaches, and please pay attention to your neck, because I think if you fix your neck, many of your headaches will get significantly better, right? That's my bias. It's just coming out. And then successful treatment is usually a combination of everything that I've talked about. When you have complex medical problems, there's seldom one thing that you can do. We can't just throw medicine at you. Does medicine have a role? Of course it does. Ibuprofen, Tylenol, caffeine, it all plays a role. CGRP medicines like Nurtec or Ubrelvy, triptans. I don't ever advocate against those. But the problem is so many people use those and then don't fix the other potential triggers or lifestyle things, or fix their neck and they have problems. So with that being said, I'm going to wrap up my presentation, stop sharing, and I want to open it up for some discussion.